I'm Randy Hecht, and I appreciate everyone who, after a long day at the first day at ASCO GI, has shown up there for our Medscape Oncology discussion tonight called Line by Line Strategic Decision Making in Advanced Colorectal Cancer. This is an interactive meeting, and so you'll be able to ask questions. You'll be able to ask questions virtually, plus we'll be around afterwards as well if you have other questions. I know that there are a much larger number of people who are online who will also be able to ask questions. You can use your own technology. There is a QR code, and you can use with your own device to actually look at the slides which are available. To also ask questions, and we also have polling questions as well. You can see where the Wi-Fi network is, as well as the password. So as I mentioned, this is called Line by Line. Some people feel that one of the original sins we did was coming up with the idea of lines in colorectal cancer. However, this is how we treat, and this is actually often how drugs are approved, but strategic decision making in advanced colorectal cancer. I am joined today by two distinguished colorectal medical oncologists. As I said, my name is Randy Hecht. I'm at UCLA. I run the GI cancer program. Dr. Dominic Modeste is to my right. He's a professor at Charité in Berlin, where he's the boss and runs the cancer center. Next to him over there is another colorectal expert, Kanwal Raghav, who is a GI oncologist at MD Anderson, as well as many, many other titles that you can see here. So I think it's going to be a good discussion, and we do look forward to it being interactive. So this is the agenda tonight. The first is setting the stage, just some early discussions and background about colorectal cancer. A little bit, this is like bringing coals to Newcastle, because if you're at ASCO GI, almost everyone here has a lot of experience in GI, but it's always good to go over things. And then we're going to start about biomarkers, which is finally sort of revolutionized, or at least updated, what we do in colorectal cancer. We have several cases that are biomarker driven that we'll talk about. Then we'll talk about maybe some new trials and some new data and possibly some new drugs at the end. And then we'll have a discussion as well. So first, let's talk about, I think this is mine. First, let's talk about, colorectal cancer. People in the room understand that colorectal cancer is an important disease. It's the second most common cause of cancer death in the United States, and it's not just a major cause of morbidity and mortality in the United States, but also worldwide. There are roughly 150,000 cases in the United States, and unfortunately about a third of those people will end up dying. Globally, a million people will end up getting colorectal cancer, and for various reasons, up to half of those people will die. One of the most interesting things that's happened over the last decade or so, and not just interesting, but unfortunate, is that we always think of colorectal cancer as a disease of middle-aged and older people, which continues to get older as I get older. Once you get beyond people with inherited predispositions, and everyone in this room probably knows that the incidence in younger people 25 to 49, is increasing, and even though people have ideas as to why this may be happening, perhaps environmental or diet, this is, at least in the institutions, I think that where we are, we're seeing more and more of those patients. Unfortunately, we do not necessarily diagnose colorectal cancer at an early stage. I'm originally a prevention person, a gastroenterologist. I've done thousands of colonoscopies. I'm still surprised that we're doing screening colonoscopies, because we still do not screen patients well enough. And so when patients are diagnosed, only about a third of patients have really early cancer, about a third have regional metastases in lymph nodes, and roughly about a third have distant metastases. And of those patients with regional metastases, a quarter or more of those will end up recurring. 5-year survival, which you can see here, is actually very good with early colorectal cancer. However, in patients with metastatic disease, there's some people who just do really well with incurable disease and long-term treatment. The majority of the patients who are still alive 5 years later are due to metastectomy.
So good evening, everyone. Thank you, Randolph, for the nice introduction. Getting it right from the start and why biomarkers belong up front is the title of my talk. Maybe a bit unusual, I'd like to present the answer right away. Why do biomarkers belong up front? And I think these data, although I think they have been reproduced in several databases, in trials, in the SEER database, in registries all over the world, sometimes don't find the attention that they deserve, because I think sometimes we really focus on advancements and new data wherever they are. But the truth in colorectal cancer is that although we have made significant progress in the development of treatment, we still face this funnel effect, which is displayed here. And what we have learned is that if we treat a 100% population in the first-line therapy setting, even if things go well and we address ECOG 0 on 1 patients who are fit and super prepared to be even treated with triplet chemotherapy, like in these Italian trials, we have a drop of 20 to 25% per line of patients that are fit to receive the next treatment. And what is not shown in this picture is also, of course, that the efficacy goes down in a very similar fashion. So we have a reduced population per line with a reduced efficacy available from the drugs in these lines. So we have a double reduction of what we can offer to the patient. And for that reason, it's very simple to understand that first-line treatment matters much more than all of the other treatment lines. And also, if you look into the other graph that shows how quickly other treatment options are used in the disease course of patients and how short patients can stay on these treatments, I think that somehow highlights also that we have a serious problem with declining efficacy, and that, of course, if we want to maximize benefit, we should try to maximize benefit in all patients affected and not in the subgroup of patients that manage to reach a certain subsequent line. So what do guidelines tell us? What can we test, or what do we test? I think it has become incredibly crowded compared to what it was the standard of care when I started my career, which is not so long ago, 1.5 decades. I think we have now a rather global consensus that MSI, MSS needs to be characterized prior to treatment start. I think that is the most important biomarker of all of them. Maybe although that the patients are not so frequent, making a substantial difference in terms of also cure rates, as Randy has shown. I think the cure rates of 16% are easily lifted maybe in the future, at least by the few percentages of patients that are fit to receive immune checkpoint inhibitors up front. So which biomarkers can be tested or should be tested in the frontline setting? It's not incredibly complex, but I think we can all agree that at least a limited panel diagnostics covering KRAS, NRAS, and of course also the specific mutation variant, I think that is of growing importance. We have G12C trials already, and we will have trials on G12D pretty soon on a broad spectrum, and maybe also other variants. That's mandatory, and I think although we did not have anything to offer specifically in terms of being a predictive biomarker, testing for BRAF is a consensus that we've reached years ago. Knowing that in terms of prognosis, it might be good to know that a patient has a BRAF mutation, and also having that in mind to plan ahead in terms of second and third line treatment. I think since this year or last year, and the developments that we've seen in Breakwater, we have that as an upfront biomarker. And of course also HER2 overexpression, whether you take an immediate consequence out of the knowledge that a tumor is HER2 overexpressing is something that could be known upfront, and maybe also somehow shape your decisions, or at least guarantee that you can take a turn and try to organize for respective drugs. All the other biomarkers I think are worthwhile to know. We are testing them on a broad spectrum, but I think we can admit that this is maybe not mandatory for untreated patients in a community care setting. So what do we expect when we panel up front? It looks a bit like NSCLC, although I would still argue it's not quite the same. The unfortunate knowledge at the moment, I hope that will change quickly, is that the attractive biomarkers, especially that are truly attractive in terms of shaping the treatment, are not really frequent. If you look into RET fusions, NTRK fusions, POLE mutations, MSI high, maybe even BRAF being more frequent, all of them together are less than 15%. And of course, the RAS mutant population now at the moment is a rather unfavorable predictive factor. Maybe that will completely turn upside down. This is my hope for the next years, that maybe in 2 or 3 years we'll stand here and say, well, it's a good thing to have a KRAS mutation because we can do something and the prognosis is completely shifted. But at the moment, these are bad prognostic factors and not really predictive. So what do we know about all these biomarkers? The hopes that we always have is that it happens like the first line. We have a biomarker that we know is prognostically unfavorable, correlating with a bad outcome, but has a predictive value, and if it addressed, turns the prognosis into something very favorable. So I think now, with the treatment that we have, MSI high is the best prognostic factor we have and the most powerful favorable factor. It was the opposite with chemotherapy, but now is different. And I think we've seen similar things with the BRAF trial last year with Wakewater, shifting the outcome into a completely unknown range, which was, I think, reserved for patients being non-mutated so far. So what we see here is that the prognostic value is maybe something that we have to rewrite in a few years, because if addressed properly, that changes. What is also important is something that is always discussed with practitioners. Should we test patients upon progression? And I think both answers are true depending on the context. We cannot rebiopsy everyone on any progression, on any drug, irrespective which drugs that are. However, we know that targeted therapy, so if we have used targeted therapy, can lead to alterations that, at least in some settings, we can address. And if that is the case, or at least a possibility, I think the answer 2 is the better one. Anyone who treats breast cancer on a regular basis or has treated in the prior osimertinib frontline era lung cancers knows that retesting somehow completely changes the whole fate of a case and a patient undergoing therapy. We are not quite there in colorectal cancer, but I think we will have more and more scenarios in which the second answer is the one that we would full-heartedly support. So, what are the challenges that we have? I think we still have, and I'm not so disappointed by 73%, a lot of patients who are not treated with guideline concordant biomarker testing. I always defend a lot of colleagues over these statistics, because it's always the question when you take the measurement. So what is the landmark analysis when you say you have started treatment and you don't have the result? Because if you have a patient in need that needs immediate treatment and you get the NGS result after 3 weeks, which is maybe an average thing, and this is a failure, that's maybe not entirely fair. However, I think we have to face that part of the story. And especially in the US, which I think is a completely different scenario with completely different distances and also care systems, to have a workflow available to get hold of the tumor, to have a trained pathology-initiated reflex testing for therapeutic biomarkers in case the patient shows up for the first time, at least for me, and this is what we always try to do, key factors to ensure that at least the timing ensures a certain chance to have the biomarker results ready before the treatment is planned. However, I admit that how well ever you organize that setting, you will always find patients who somehow screw up your whole plan because they come in need. It's not their fault, of course, and the tumor is not available at your site, and you have to take a decision without the knowledge. So what can you do? I think liquid biopsies for the future will somehow prevent some of these problems, because if you have a minimal invasive blood draw and you can take the results from that, that of course helps. Tissue testing, of course, is a bit more complex, and you have to get the tissue, and if you don't have it, you have to have a rebiopsy. I think for the initial diagnosis, both options are somehow valuable, and in some cases, of course, the liquid biopsy can replace the tissue biopsy. Are there also knowledges or biomarkers that are somehow non-biologic but carrying biologic information? It's still a slide that I enjoy a lot. Of course, we still have the problem that although we know that left and right, of course, has a biological background that we cannot completely explain or at least describe, we still argue with that as being one of the key drivers of decision-making, limiting EGFR antibody use to patients with the left-sided tumors. Of course, we have made progress this year, and to really set the scene for the future, I think this is the final breakthrough for completely molecular stratified therapy, which came to us in 2025. Implementing BRAF V600E as an undebatable backbone of biomarker testing up front after breakwater, providing such a crazy benefit in terms of overall survival, and of course checkmate 8HW, confirming and, at least from my point of view, also overpowering the already very, very nice and practice-changing Keynote 177 trial. So these two biomarkers, I think, have really established themselves as something that we cannot miss. So if we accept that first-line therapy is the most important therapeutic intervention, the best regimen should be used. I mean, that's super easy, which typically, at least in colorectal cancer, includes a targeted agent, including bevacizumab, of course. I think that immediate testing and rapid testing in the initial diagnosis setting is key. It should at least include RAS, BRAF, MSI, MSS, and HER2 amplification, which I think is an emerging frontline target, and if the respective trial is positive, will be quickly implemented into the guidelines. And of course, if molecular testing cannot be completed quickly, and of course that is something that happens in practice, at least MSI should be ruled out to avoid starting chemotherapy in this small subset of patients. I think this is the least we can do. And with that, I'm giving back the control.
Thank you very much. Thank you very much, Dr. Monas. So we're going to now go to cases. And to start off, Dr. Raghov is going to start with the first case.
Good evening, everyone. This is the very interesting part of this conversation. So thanks very much for taking us over some of those first-line molecular markers. We all recognize that colorectal cancer is now divided into all these small pies. So I'm going to take one of these pies, which has a very big impact on how you manage this disease. And this is a case of a BRAF mutant CRC. So we're going to talk about a case that all of us have seen in the clinic. It's a 62-year-old woman presented with some right-sided abdominal pain, some unexplained weight loss, iron deficiency anemia. These are common symptoms as how right-sided tumors present. ECOG PS is one. The colonoscopy ultimately reveals a large friable mass in the ascending colon, which shows adenocarcinoma, which is poorly differentiated. This is a 5-centimeter primary tumor, and imaging shows multiple bilobar hepatic metastases. Largest one is 4.3 centimeters and multiple lung metastases. So this is clearly, right from the get-go, one of those cases where you are not going to find a resectable situation. Molecular tests were done at diagnosis, as they should be done. This is NGS, and it showed RAS wild type, BRAF V600E mutation. This was detected on NGS, and the patient is proficient mismatch repair. The CEA at baseline was 202. So question for the audience, how would you treat this patient in first line? So choose any of these options that you feel is the best option. Okay, so about 32% people said Bev Folfox, which would be chemo plus the VEGF inhibitor. Nearly 40% people would give encorafenib, cetuximab, FOLFOX, so that's BRAF, anti-EGFR, and chemo, and then some spattering of other responses. So this is a good beginning to start. So I'm going to go and show you what the guidelines state. So the guidelines for first-line therapy option for this patient, which is a BRAF V600E mutant patient who's MSI stable and otherwise fit, is a combination of BRAF inhibitor encorafenib along with an anti-EGFR agent, cetuximab or panitumumab, along with chemo. And we're going to discuss some of the data that supports that recommendation. So first and foremost is that all BRAF mutations are not made equally. There are three large classes of BRAF mutations. BRAF plays a very important role in the pathway that supports colorectal cancer. This is the RAS-MAP kinase pathway. BRAF V600E mutation is a class 1 mutation. They can form monomers. It's a highly active mutation. And the reason why this is important is because there is a number of mutations in colorectal cancer that are non-V600E. And this is important to understand because the data that we are going to discuss beyond this is specifically designed for BRAF V600E mutation. The same principles do not stand true for class 2 and class 3 mutant BRAF. One of the other important factors to know from this slide is that the EGFR receptor tyrosine kinase along with RAS BRAF axis is critical because unlike melanoma where single agent BRAF actually has activity, when you try to do the same in colorectal cancer, it actually up-titrates the EGFR signaling, so you actually need both BRAF and anti-EGFR inhibition for sustained responses. BRAF mutant tumors are actually resistant to chemotherapy as well as EGFR inhibition. In fact, second to MSI, this is a very poor prognostic factor. If you've seen patients with BRAF mutations, which are V600E, you'll notice that these patients have a large tumor bulk and they have a very aggressive course. The median progression-free survival on any chemotherapy, for that matter of sake, is actually pretty low. So you can see from these plots, whenever you have a mutant BRAF and a wild-type RAS mutation, you're unlikely to benefit from an anti-EGFR chemotherapy option. So that's the wrong answer if you have a BRAF V600E mutant, even though the fact that they are RAS wild-type, and they almost always are because these are two mutually exclusive events, they do not benefit by single-agent anti-EGFR or anti-EGFR in combination with chemo. The clinical proof of concept for incorporation of BRAF-targeted therapy within colorectal cancer was established by the Beacon study. This was a second-line study, so patients had progressed on first 1 to 2 prior treatments. They were ECOG PS 0 or 1, and they'd not had any treatment with a RAF, MEK, or EGFR inhibitor. The standard of care at that time, because these are RAS wild-type tumors, and while we recognize that this is a very prognostic factor and people do not benefit from anti-EGFR, it was still the standard of care. So that's the control arm, which is cetuximab, irinotecan, or cetuximab FOLFIRI, so anti-EGFR and chemo. And then there were 2 other arms, the triplet arm, which was encorafenib, cetuximab, and binimetinib, which is a MEK inhibitor, and the doublet arm, which is encorafenib and cetuximab. There were dual primary endpoints, overall survival of the triplet arm versus control, and then objective response rate. This is some of the data regarding that primary endpoint. As you can see, the median overall survival of the control arm was 5.9 months, which highlights the poor prognosis in these patients, but that of EC or EC and binimetinib was 9.3 months. Because the benefit of even the doublet was very comparable to the triplet, the approval and the guidelines actually do not include MEK inhibitor in the standard treatment of these patients. Patients after this were treated with encorafenib and cetuximab in second-line setting. This was taken forward since these patients have poor prognosis, and we saw how Dr. Modest showed us the attrition rate that happens between first and second-line treatment. This is untreated patients, newly diagnosed, that were BRAF V600E mutations. This is a phase 3 breakwater trial. Patients have measurable disease, and they were randomized 1:1:1 into EC plus EC and chemo, because we wanted to see whether chemo is required, and then the standard of care, which was any combination of chemotherapy with a biologic. There were dual primary endpoints of PFS and objective response rate, and this study is one of the key trials in establishing the role of BRAF inhibition in first-line setting. So this is the progression-free survival by blinded review, and you can see that there is a significant improvement of that progression-free survival with addition of BRAF inhibition, anti-EGFR, and chemo. So EC plus FOLFOX, median PFS was 12.8 months, compared to standard of care, which is chemo and biologic, that was 7.1 months, and just BRAF and anti-EGFR by itself, even without chemotherapy, gave us a similar PFS curve. This is the money slide, according to me. This is the overall survival, and you can see that these patients have very poor overall survival, about 15.1 months in general. And remember that at this time, there were some patients in the control arm that, or the standard of care arm, that could actually cross over and get BRAF therapy because it was approved as standard of care in certain settings. And I think more than 50% of patients actually did get some sort of BRAF-directed therapy. Despite that, early institution of BRAF therapy in first line led to almost doubling of overall survival from 15.1 months to 30.3 months. The BRAF and anti-EGFR, so chemotherapy-free arm, while it did not do as well as chemotherapy plus EC, it still did better than the standard of care arm. So bringing BRAF upfront is critical, and this is an important slide demonstrating the undoubtable value of using anti-EGFR, BRAF inhibition, and chemotherapy in first-line patients with BRAF V600E mutation. This is a toxicity slide. It shows that overall the side effect profile was comparable between the two arms. Encorafenib was, of course, associated with more BRAF direct related side effects, such as arthralgia, rash, and dermatitis. But the treatment discontinuation because of treatment-emergent adverse events occurred in only about 13% to 25% of patients who got these treatments. The same thing happened in about 17.5% on standard of care arm. So now let's throw a little bit of, so how this patient was treated according to the breakwater regime, was started on encorafenib, cetuximab, and modified FOLFOX6. They tolerated treatment very well. You can see there was a great CEA response, 4.2. First restaging showed significant reduction in hepatic lesions, a clear partial response, ECOG-PS improved, and the toxicities were mild and manageable. This is some of the scans from this patient after 5 months of EC plus FOLFOX. The patient was actually transitioned to maintenance 5-FU and EC due to grade 1 neuropathy, which we all know limits how much oxaliplatin exposure any patient can get. But the patient has had a continued PR after 11 months of treatment with nearly 40% reduction in tumor size. Same case, we're going to change the setting a little bit. So what if this BRAF mutant patient did not have a proficient mismatch repair, but had an MSI high or deficient mismatch repair tumor? So this is an important clinical question because there is a big overlap between MSI high and BRAF mutant patients. This is not an unusual scenario. So the question to answer this comes from whether you would use immunotherapy, which we know works in MSI high or deficient mismatch, or would you use a BRAF-directed therapy? This is Keynote 177, stage 4 patients, first line, pembrolizumab versus investigator's choice, 1-to-1 randomization with PFS and overall survival as the endpoint. And you can see that these are the PFS as well as median overall survival curve. Remember, the objective response rate improved with pembrolizumab. And more critical than the improvement in the objective response rate is the hazard ratio for both median PFS, for both PFS and overall survival. You can see there was doubling of overall survival from 36 months to 77 months, and then from 8.2 PFS to 16.5. So doubling of PFS and as well as overall survival with single agent immunotherapy, immune checkpoint inhibition in patients with MSI high tumors. Remember, some patients of this were BRAF mutant. When you look at the subgroup analysis, there was no difference in patients who had BRAF V600E mutation versus wild type in terms of the benefit that they were deriving from immunotherapy. And this is a very important key takeaway from this. As expected, pembrolizumab does cause adverse events, not as many as chemotherapy would cause, but most of them are immune-related adverse events, and these are sometimes very serious and may lead to discontinuation of drug in as many as 6 to 7% of cases. This is Checkmate 8HW. It asks a question of whether intensification of MSI, of immune checkpoint inhibition, so dual immune checkpoint inhibition could actually do even better in the same kind of population. So first line, patients who were MSI high or deficient mismatch repair, ECOG PS0 or 1, got either nivolumab, single agent, nivolumab plus ipilimumab. So the nivolumab would mirror pembrolizumab as single agent, and then investigator's choice of chemotherapy plus biologic. And the primary endpoint were again dual primary endpoint of PFS as well as OS. So these are very impressive curves in my opinion. Again, look at that median PFS. This is unlike what we've ever seen in colorectal cancer with any treatment. When you actually look at Nivo plus Ipi arm, I know Dr. Hecht showed us the slide of 16% survival for stage 4 patients. This is 64% survival at 4 years, and the tail of the curve indicates that some of these patients are actually potentially cured from metastatic disease with just systemic therapy. So median PFS has not been reached, and neither has median OS. The hazard ratios were very significant. Again, BRAF patients were allowed, and when you look at the subgroup analysis, there is no evidence that BRAF mutant patients do any worse on immunotherapy. In fact, the degree of benefit is exactly the same. Side effect profile is very similar. Of course, this is dual immune checkpoint inhibition, so the side effect profile is consistent with immune inhibition and a little bit more toxic than single agent pembrolizumab, but the benefits are still significant. So in summary, EC plus FOLFOX is the new standard of care for first-line therapy in patients with BRAF V600E mutant colorectal cancer whose tumors are proficient mismatch repair and MSI stable. For patients who have this BRAF V600E mutation, but they do have deficient mismatch or MSI high, the first preference would be given to immunotherapy because of the large degree of benefit that is seen in these patients, irrespective of their BRAF status, as long as they are eligible for immune checkpoint inhibition. And EC plus FOLFOX remains a viable option after immunotherapy. I'm going to stop there, and thank you.
Go around this way. My case does not have quite as much information, so I think the timing is perfect. And so I'm going to talk about KRAS mutant metastatic colorectal cancer. This case is illustrative, and I think is hopefully just sort of the appetizer to what we might have in the future, as Dr. Modeste was talking about. So this case, there's a 60-year-old woman presented with rectal bleeding. Remember, I said that we don't do such a great job in finding cancers early, unfortunately. She had a friable mass at the splenic flexure, moderately differentiated adenocarcinoma, also inoperable because not only did she have liver lesions, but she also had retroperitoneal lymphadenopathy. Biomarker testing was done, as was appropriate, and she was found to have a KRAS mutation, as do about half of patients, but in this case, it was in the 3% of patients who had a G12C mutation. Patient was initially treated with chemotherapy with capecitabine and oxaliplatin because of the RAS mutation with bevacizumab. And you can see the you can see the original scans. After about 4 months, the oxaliplatin was dropped, and that's as per the Optimox strategy. We're having discussion about the use of oxaliplatin up front, which is what we tend to do in the United States, but of course we're concerned about neuropathy. Patients started on maintenance with capecitabine and bevacizumab, but unfortunately, as often is the case, particularly with patients with RAS mutations, she had significant progression. Since we were talking about lines, and that I think it was also a really good slide initially, and that Dr. Modeste was talking about, is that we forget, we think of first-line trials, we think of second-line trials, how many people really do fall off and are not eligible for treatment. And in fact, the data that he showed were people who were eligible for treatment in the Italian tribe trials, while the patient we see in our offices often are much sicker and may not be able to go on to second-line therapy. But this person was able to. Started with FOLFIRI plus bevacizumab. Response rates in second line actually are much lower than in first line, and she had stable disease. And then eventually, unfortunately, after a relatively short period of time, began to progress. So what would you do next for this patient who has who's now third line with a G12C mutation? Can you still read these? Do you have them in front of you on the? Okay. We're tabulating. So the largest group was a combination of sotorasib plus panitumumab, which we'll discuss. We'll talk about adagrasib, fruquintinib, and regorafenib, or small molecule. There are small molecule tyrosine kinase inhibitors that are approved in colorectal cancer. Trifluridine tipiracil is also approved in colorectal cancer, and it is always reasonable to say not sure. So these are guidelines, and you can see it gets busy as to what happens after someone has already progressed on first and second line therapies. Often what happens, particularly in second line, is what you didn't get first line, but by the time you get to third line, our options are definitely more limited. What we're hoping is actually for something that is biomarker directed, like Dr. Modeste was talking about before, but in this case, we don't have MSI high, we don't have BRAF, we don't have HER2, but we do have KRAS, with rare patients who have a KRAS G12C mutation, and that's shown in red. So as I mentioned before, roughly about half of colorectal patients have either a KRAS or an NRAS mutation. G12D is the most common. G12V is common as well. G12C is relatively uncommon, and as someone who's done trials in this setting, particularly before we routinely were doing next generation sequencing, there was some burnout to screen 30 patients to get one. But it is about 3% of patients overall with colorectal cancer, and 7% of patients with total with KRAS. So let's talk about this. KRAS in general, patients, as was already discussed, generally do not respond very well to anti-EGFR therapy, which makes sense because the mutation is downstream of where you're blocking. So KRAS has already been discussed. It is basically an amplifier circuit and is not just important for colon cancer, but of course 95% of pancreas cancers, as well as about a third of lung cancers. These really are the first breakthrough drugs in what was historically called the great undruggable target, which was KRAS. People have been working for 20 years, including groups up here at UCSF, in really trying to, to drug the undruggable. And the first two drugs out of the gate are adagrasib and sotorasib, which are covalent inhibitors. They're irreversible. They bind. Now, one thing that was shown was that, similar to the setting as was discussed with BRAF, is that there are feedback loops, so blocking upstream with an anti-EGFR, and we'll show some of the data, is more effective. So this is one of the seminal trials, CodeBreak 300. I believe, Dr. Modeste, you were part of this trial as well and has presented some of the data. This was really the larger registrational trial using sotorasib together with the anti-EGFR panitumumab. These patients all had at least one prior line of therapy. They cannot have had a prior, at this time, actually, when this was done, other than adagrasib, there really weren't any others, sort of standard randomization. This was one of the early trials to use the Project Optimus, looking at different doses. One thing we've been really good at in colorectal cancer is choosing the wrong doses. We did this with irinotecan and regorafenib, and so the FDA has made an effort to, at least early on, rather than post-marketing, to try to look at different doses. So there was sotorasib, 960 milligrams a day, randomized 1:1:1, sotorasib 240 milligrams a day, both with panitumumab versus standard of care, which, as this was an international trial, was just TAS-102, trifluridine tipiracil, or regorafenib. Numbers are relatively small for a large trial, for a trial like this, but remember, this is only 3% of colorectal cancer patients. Primary endpoints, PFS, once again, probably because of the size, but there are also key other endpoints, particularly, as was discussed, the one that we care perhaps the most about, which is overall survival. So these are the efficacy data that was published initially in the New England Journal a couple years ago. And so what you can see is that both arms, from a PFS standpoint, the 240 as well as the 960, together with the anti-EGFR panitumumab, was better than standard of care. There was a significantly higher response rate with the higher dose, and somewhat increase in PFS with about a month and a half increase in PFS with the higher dose. OS was not quite as different for this. However, there was still an improvement with about 30% with a hazard ratio of 0.7. Not statistically significant, but remember, these numbers are relatively small, and this was a secondary endpoint. These trials led to some of the trials that led to the approval of sotorasib. Now, the other drug is adagrasib, which was originally from Mirati. Adagrasib we worked with early on. Similar drug. This time it was combined with cetuximab. I don't think it really makes any difference what your anti-EGFR. And in fact, in the guidelines, they really don't specify. This was mostly for commercial reasons why one was chosen versus the other. So this was actually a non-randomized trial, but we're not supposed to do cross-trial comparisons, but yet we do. In this trial, response rate was the primary endpoint, but there were other secondary, actually safety, but then there were a number of other efficacy secondary endpoints. So what you can see, this was also published in the New England Journal by Rona Yeager. What you can see is that monotherapy still had activity, and you can see in the waterfall plot with a response rate just a little bit under 20%. On the other hand, the combination with an anti-EGFR had a significantly better looking waterfall plot, as well as a significantly higher response rate. And this was approved as well by the FDA. PFS is similar. Once again, this is non-randomized, and we're doing the cardinal sin of trying to compare. These patients do get what I would say is a clinically reasonable and clinically important improvement in PFS. This was done by blinded independent review. And overall survival is hard to say because, remember, these are sort of carefully selected patients who were at large institutions that were accruing to this trial. The adverse events that we see, and it's one of the things as medical oncologists, is that not only do we choose which drugs to give, but we also have to manage, as was discussed earlier, what the adverse events are. Patients also care about adverse events and help us decide what drugs to use depending on the adverse events. Really, mostly what you would expect, particularly with an anti-EGFR. Hypomagnesemia is a class effect. Was seen in both sotorasib plus panitumumab as well as adagrasib plus cetuximab. Otherwise, you would see dermatologic changes. One thing that's really important that we've learned from anti-EGFR is early introduction of drugs like minocycline, antibiotics, or doxycycline, as well as steroids, as well as close follow-up, particularly for paronychia and other cutaneous toxicities. That's one of the things that really helps people stay on drugs and get benefit from them and also have a better quality of life. There is currently the Crystal-10 trial, which is a second-line trial. I'm actually on the steering committee for this. We are still waiting for this to come back. Joseph Tabanero is the person who's in charge of it. This is adagrasib plus cetuximab versus standard of care chemotherapy in the second-line. PFS and OS are co-primary endpoints. This is not read out, but hopefully soon. Just so you know that even though those are the drugs that are approved, there are actually multiple KRAS G12C. I just chose one. Data waterfall plots look fairly similar. I think at some point we'll probably have multiple G12C inhibitors to choose from. And I think all of them will be with anti-EGFR. So one of the things that we know from signal transduction inhibitors is that there's resistance. We're not curing anyone. We didn't cure people with anti-EGFR, and we're not curing people with anti-BRAF, and we're not curing people with G12C. And this is actually a really nice workup from translational work from the CodeBreak 300. And not surprisingly, particularly when you block G12C, you have other RAS mutations as well as other pathways that are turned on. And we're not lung cancer yet, where you start with one drug and then you have resistance and you may end up with another drug, but hopefully that may be something that expands the time that patients can stay on therapy and get benefit. So to summarize, actually, I don't know why this is in here. I just realized this is more for you, I guess, but I'm going to summarize. I'm going to summarize for my colleague that BRAF, that the new standard of care is encorafenib plus an anti-EGFR plus modified FOLFOX6 in first line, and it is important to test up front. Patients do better if you start with the most active agents. It's also important, and this should be done reflex whenever someone is diagnosed with colon cancer, is to check for mismatch repair or MSI. Usually now it's just staining for mismatch repair. They're about 95% concordant, and start with immunotherapy, either 1 or 2 checkpoint inhibitors. If someone progresses and they're BRAF mutant, one is that if they're BRAF mutant, you should start with immunotherapy, and if they progress, then still anti-BRAF therapy is reasonable. So now back to Dr. Modis.
So I have the privilege to close the whole circle and focus on the third-line setting and beyond. To reflect a bit, what does that mean in clinical practice? I think Randy told in the beginning that this concept of line is a bit questionable. I mean, we do these line definition because it helps us to label drugs, to develop drugs, and of course, in reality, we all know that often enough this continuation of therapies does not work the way it is supposed to be. So usually, if we talk about third-line setting and beyond, that means that 2 regimens have been given. However, leading to some unclarities, of course, because does maintenance therapy count? You can take that one or the other way. And of course, also does adjuvant therapy, in case that this is a secondary event, count into the numbers of regimens used. Usually, if you're pragmatic, you can say it means that fluoropyrimidines, irinotecan, and oxaliplatin have been used, VEGF-targeted drugs have been used, and in case that there is another target leading to anti-EGFR, BRAF, or immune checkpoint inhibition, this also should have been used. And of course, you can easily make up cases where you need 3 lines of prior therapy to use all of these drugs, or just 1 line of therapy to use the available drugs for the setting to end up in this so-called third-line scenario. So typically, when we develop drugs in colorectal cancer, and I think that was pretty true until quite recently, we only had, in fact, 3 defined scenarios for metastatic disease, and the middle one, the second line, hasn't been addressed very frequently after a few statistically significant, though clinically marginally active scenarios around 10 years ago, 10, 12 years ago. So we have first line, that's easy to define. You have untreated patients for metastatic disease, and we had this last line, third line scenario, with the second line scenario in between. And now I think what we have seen in the last 2 to 3 years, that this third and beyond line setting has been differentiating itself into something where we can clearly define a third line setting and something that is now maybe the beyond 4th, 5th line setting. So I think that in itself is some kind of an advance in colorectal cancer, that we start defining even a third line standard, which I think was not the case 10 years ago. So what kind of options do we have? And as the 2 esteemed colleagues have focused on targeted therapy, I will, at least for the majority of the lesson, will focus on non-targeted third-line options and start with the case. And I already received a lot of questions for that, because it is a case that is maybe very European to you. It was a 58-year-old man with a classic metachronous metastatic colorectal cancer of the sigmoid section with diffuse lung lesions. It was about 50 lesions in total, so that was completely unresectable. It was a left-sided tumor with a double wild-type status, HER2 negative, so very classic. And of course, they started cetuximab, which we usually do in that case. So I'm not in a tradition there where FOLFOX is a very established first-line option. So I was trained to start FOLFIRI. The patient switched after progression to a classic second-line regimen, at least from my point of view, a classic second-line regimen, which is maybe your preferred first-line option for bevacizumab. I still believe that's a great sequence of therapy. However, the patient developed polyneuropathy pretty quickly with a partial remission and switched to a classic maintenance setting. So the oxaliplatin was stopped. So the key question now, after progression of the second-line regimen, what would be your preferred choice to continue the treatment? Given that the patient has responded to cetuximab very well, you can use EGFR rechallenge for fruquintinib, regorafenib, trifluidine, tibulizumab plus BAF, trifluidine, tibulizumab alone, or unsure. So I'm thankful for your opinions. Okay, there's a clear winner, which is trifluidine, tibulizumab plus bevacizumab. Very little EGFR rechallenge, a bit more fruquintinib, little regorafenib, and trifluidine, tibulizumab alone, of course, is also not very frequent, and at least 19%, so 20%, 1 out of 5. Not entirely sure what to do. Okay, at that point, we will review what is available. And we will start with a German drug which isn't available in Germany, actually, which was regorafenib, which was the first, I think, of these last-line trials establishing all the options that we're now discussing. So the correct trial compared regorafenib to placebo in last-line patients that were mandatory to have had fluoropyrimidine, irinotecan, and oxaliplatin. And as you'd see, there was a certain advantage in terms of overall survival, which was the primary endpoint, although maybe on an absolute level, the increment of improvement was quite relative. Given that, the drug was labeled and was started to be used throughout the world as a third-line option, although I think also the progression-free survival suggests that only a subgroup of patients was truly benefiting, because what at that time was characteristic of these drugs is that the half of the population, irrespective whether there was an active drug or not, was progressing immediately. So I think you could take away that for half of the patient, the decision whether to treat or not was completely not relevant if you look into these curves. And I think this is the major advance that we see throughout the presentation. Regorafenib, however, as a multi-kinase inhibitor, did not have any interaction with the biomarker, which was maybe also the problem of these drugs, that they address so many target structures that you find it hard to find an alteration which really drives efficacy. Nevertheless, that was it. It was, I think, accompanied with the second drug pretty quickly after 2-3 years, which was trifluridine-tipiracil as a monotherapy in the RECOURSE trial. And this trial doesn't look so dissimilar from the first one. You have the immediate progression in half of the patient here as well. So the PFS curves look pretty similar to what we've seen with regorafenib. However, I'll argue that the overall survival looked a little bit better. And of course, also I think the symptomatic toxicity was clearly better than it was with regorafenib. What at least led to, I think, a certain shift, at least in Europe, to use more trifluridine-tipiracil than regorafenib, I think primarily for reasons of tolerability. I can't switch anymore. Okay. Now, and very alike regorafenib, also this drug did not have a clear interaction in terms of clinical or biological biomarker. Okay, the story doesn't stop here. And pretty soon, with a difference of a few years, the first trial came pretty quickly. We had 2 randomized phase 3, one being a Chinese one, that was the FRESCO-1, and the FRESCO-2 being a global trial, exploring fruquintinib to placebo. So I think that was clearly a remake in a way of the correct trial, with of course now the precondition that the patients have had one of these other 2 drugs, trifluridine-tipiracil or regorafenib, prior to inclusion into that trial. So that is a bit of another scenario. And I think the major takeaway for me from fruquintinib was that the PFS curves made it to the median without being the same. So for the first time, I think we saw a last line or so-called last line therapy where not half or more than half of the patient failed therapy initially. And I think that was also the key thing that drove, although this is maybe one line further compared to CORRECT and RECOURSE trials, the overall survival into really acceptable numbers. So I think for that reason, I think fruquintinib was established pretty quickly, and also maybe because of the reason that the tolerability is clearly a bit better than with regorafenib. Okay, so while having had that, at least in China as a new option, I think at least in the Western Hemisphere, also according to what you have voted, the new standard that was arriving was the Sunlight trial with a very simple trial design, trifluridine-tipiracil plus minus bevacizumab, and I'd still argue this is maybe the best bevacizumab trial in history, coming late, however not too late. I think that was a very pragmatic trial, and I just want to pick a few aspects of that. It's the first and so far the only clearly third-line trial. So that was clearly a trial that was absolutely limited to 2 prior lines of therapy, and I think that worked in 98% of the participants of the trial. And it's the first further line trial comparing to an active comparator in unselected patients. Of course, we also had this code-break data with active comparison in that regard, but at least I think for all comers and also in the third-line setting, this is the first actively controlled trial. And I think the results are quite remarkable. I always call that the 3 months trial, because into whatever efficacy parameter you look, you find 3 months plus minus a few weeks improvement. And that holds true for progression-free survival, for overall survival, for time to decline of echo performance status. And I think given that we are addressing a chemo-refractory metastatic colorectal cancer, these overall survival and also the progression-free survival curves look extremely well. Also including the progression-free survival with a stabilization rate beyond 70%, which I think is one of the most remarkable results from that trial. So if you take an overview of third-line and later-line trials, what we have available, at least on an unselected basis, you see that the gain in median of overall survival is still somehow limited. So we don't have this later line trial for a broader population that gains us half a year or something. But with taking some kind of decent perspective, and I think that this is what colorectal oncologists have learned over the decades. I think we've made several steps that were worth being taken, and even one providing a quarter of a year of quality of life with a quite limited spectrum of additional toxic events. So, and even in this comparison of trials where 3 out of these 4 trials were comparing versus placebo, I would still argue that the actively controlled Sunlight trial is remarkably doing well in terms of hazard ratio of 61 for overall survival. So I think that was really a big step forward, and I think not many would have betted that bevacizumab in its old days of development out of patent would provide such a benefit in a non-specified treatment scenario that kind of arose as a result of bevacizumab use prior to this regimen use in the Sunlight. So what does it cost in terms of toxicity? And I think we can make that pretty quickly. In pretreated colorectal cancer, in a third line and beyond setting, you can be almost sure that any grade of toxicity just by the existence of disease will happen, because I mean we see high rates even in the placebo-controlled treatment arms. Of course, the rate of grade 3 and 4 event, which I think is the most important one, though not the only important one, is, even though there is no treatment, pretty high. So you can say that at least in many of these scenarios, a remarkable percentage of patient experiences some kind of adverse event, even grade 3, 4 event, irrespective of therapy. So the upstep in terms of active therapy, providing more toxic events and adverse events, and even serious adverse events, I think is quite manageable, because if you look into the serious adverse events as the ultimate consequence, what it means for the patient, the numbers do not increase so dramatically. So what can you do to make it better, or at least help the patient to tolerate the therapy? I think for regorafenib, the redose schedule, which was developed as a consequence of the limited tolerability and also the adherence of patients to the protocol, has eased things for the patients. For tifluridine tipiracil, of course, you can reduce the dose per square meter, which is not so easy. You have to calculate a bit, but there are good tables in the prescription information. I think the only way, or the only important thing that you remember is that you not re-increase the dose once you have reduced, because usually that leads immediately to new toxic events. And for fruquintinib, we don't have a redose schedule, and I do not really think it is a very necessary thing to have, because the majority of the patients does pretty well and is absolutely fine to be reduced in case of adverse events, which is maybe somehow a differentiating aspect from regorafenib. So what else can we do? I think there's one thing that is maybe a bit of a European obsession, and so I take the privilege to talk through that here too, because since we have a very unregulated system, we can use rather in an uncontrolled fashion any labeled drug at any point of time in the disease course, which has led to a lot of re-challenging or re-exposition of prior used drugs. That is not limited to anti-EGFR drugs, but early on I think there were good data to suggest that with anti-EGFR there's a certain rationale, biologic rationale for a re-exposition, a reintroduction, or re-challenge, however you want to put it. So the guideline includes both these later line options, both drugs are available. Personally, I favor a combination with irinotecan because I think that initially the development of cetuximab with irinotecan was rather good, leading to attractive data. However, I think, of course, this is also may be limited to left-sided patients. I do not believe so much in later line activity of EGFR in right-sided, just to say that. Tumors usually it doesn't do well, and to also set that clear. I'm also not convinced that these antibodies do differentiate from one another substantially. There might be small differences in terms of toxicity and maybe also binding spot and whatever, but if you look into the clinical data, and that is what matters for a clinical oncologist, I don't find a very well differentiating thing. So to take a few aspects of this EGFR re-challenge story, I'll do it quickly. Kronos was maybe the first doing prospectively how it maybe should be done, characterizing patient by liquid biopsy for being still double wild type, not having resistance mutations in KRAS, NRAS, BRAF, and also in that case EGFR active domain. And these patients were exposed to panitumumab solo agent, so monotherapy after failing initial panitumumab. And if you do that after a window therapy of 6 months, you can have a remarkable activity, I think, in terms that there was a 30% response rate, which I think is clearly better than many other later line options. So for a selected scenario, that seems to be a valuable treatment option. However, there are also some disappointing aspects in that story, and to take one out of these 3 randomized trials of this last year being reported, I'll take the German FIRE4 trial, and I'll take the randomization 2, which is the end of the whole algorithm here, where there was a randomized comparison of investigators' choice third-line therapy versus re-challenge with FOLFIRI or irinotecan plus cetuximab. And that trial led to data that are not easy to understand because the data itself are super attractive. If you look into the medians of progression-free survival and overall survival, they suggest that these patients were doing exceptionally well considering they are in a refractory state. However, it didn't matter which treatment was used. The interpretation of that trial isn't so easy. I think we can maybe conclude that these patients were not truly chemorefractory, but treated within an algorithm, and that if you have active alternatives to EGFR re-challenge, EGFR re-challenge is not a striking option or nothing that you must do in that setting, but something that you maybe can do. At least that is my takeaway from this very complex messages. However, the good news is there is efficacy and it can be used. To conclude, okay, for the first conclusion, I think some part of the conclusion was maybe eaten by my Apple product. Sotorasib and adagrasib, as Randolph has pointed out, that's your conclusion, so I see it now. So in the end, we come with our conclusion. Nothing's left out. Sotorasib and adagrasib are good options, I think, in a third-line setting for G12C mutant tumors. I think we can all agree that we hope that they move to the front-line setting pretty soon, and there are enough trials addressing second-line and also first-line therapy now. I think for the unselected population, the best option at the moment for a classic third-line trial is tifluridine, tipiracil plus BEV. Targeted therapies are an option for eligible patients, of course, if they are available. EGFR re-challenge shows activity, but it's not necessarily a third-line choice. You can use it in the third line, but I think you can also use it later. And of course, to remind you of testing, third-line patients should be tested for molecular alterations to see if they are candidates for HER2 targeted regimens. I think that will likely move to the front But I might be mistaken, but we know for, I think, more than a decade that in the third line and beyond setting, HER2 can be a target, although this is not clearly labeled, at least not in Europe. Of course, caution is always necessary when we make cross-trial comparisons, but I think fruquintinib appears to be clearly more active with less toxicity than regorafenib, at least from my personal experience, and is typically used as the first-line standard of care, at least in my daily practice. And with that, without overtaking the time, I think I can give it back to Randolph.
Go back this way. Nice job. Yeah, I think that maybe a paragraph got shifted somewhere in progression. So we are going to have a panel discussion, but there's also, I'm trying to set things up a little bit. So in some ways you could say that this is first what's next for colorectal cancer, then we'll have the panel discussion. Also, we should have time for questions, plus we have time for online questions as well, not just people who are here. So one question is, what are the novel targets that, now there's a part for me to talk about, but I think we should discuss what novel targets or agents are you most excited about. Maybe we should actually ask the panelists, this would be a good time. Either of you, actually Dr. Raghav, since you didn't talk last, what targets are you most interested in for colorectal cancer? Any thoughts?
Yeah, I think, this is an exciting time as far as colorectal cancer is concerned. There are lots of antibody drug conjugates that are coming up. I think that those are immensely exciting, but whether they will work as single agent or will there be combinations that are required is a verdict that's still out there. I think there are next generation HER2 as well as BRAF compounds that are coming up, and which also I think I'm excited about. And there is some degree of excitement that I have about bispecifics that still are answering the question of whether
IO bispecifics or signal transduction bispecifics?
IO bispecifics, just to see this. But when we talk about IO therapy, although we've exploited this very well in MSI, there is still a large amount of MSS space that's still pending. And there are T-cell engagers and others that are on the horizon. So my hope is that we'll still be able to crack immunotherapy in MSS, but what we'll see.
So Dr. Modest, anything here or unfortunately not here that you would want to discuss, since today, it's not colorectal cancer day, but other targets?
I'm still having a lot of hopes for RAS inhibition on a broader spectrum. I think the respective companies so far, as usual, take easier entities first, unfortunately for us in colorectal oncology, but I would still argue that G12D inhibitors and maybe RAS-on inhibitors and all these drugs may also crack the MSS space to a certain extent. And maybe provide a benefit. Whether they work as well as in other entities, I think we're usually a bit skeptical, but that's something. And I'm also, maybe not yet excited, but with a certain interest, I noted that there are more and more cell therapeutic trials, especially from China, coming up at large meetings. Although the efficacy data and the cost-efficacy ratio is maybe clearly not in favor yet of that, just the fact that it seems possible to identify targets for CAR T cells, even in GI oncology, is something that may need a decade more, but it's coming.
Something that we've been working on a lot, and the problem is we don't have CD19, and
unfortunately,
so that all that all the good targets seem to have unfortunately have a lot of on-target off-tumor toxicity. And I think what you point out, it's not just a monetary value proposition, but it's also, you started off leading about toxicity for drugs like regorafenib, and so when you need lymphodepleting chemotherapy, and the question is how long a benefit, if you don't cure someone with cell therapy, would be considered reasonable, because obviously that in the in the lymphoma space and hematologic space, they're getting long-term benefit. And there's no question, they're getting cure equivalents. And I'm not aware of any, whether it's a TCR or whether it's a CAR T but we certainly are lots of places are working on it. MD Anderson, we are working on it. I think there's there is a lot of interest. And so what I would say is that it's interesting that you brought up about IO bispecifics, and both of you have brought up, I always say that I'm working with my trials for the 97% of people who are MSS or with proficient mismatch repair. That's been an incredibly difficult thing to basically space to work in. I'm going to talk briefly about, one of the first trials that with IO, but there's certainly, I was wondering something that has been out there for a while. Do you have any thoughts about combinations of like FC enhanced CTLA-4s or together with PD-1 or PD-L1s or other, Rego-Nivo has been out there, Rego-Nivo-Ipi. Any thoughts about that?
Yeah, I mean, I think one of the keys here is like so far, the reason why we've not made as much success, or headway is we've also been coming at it from a very blunt, force yourself through colorectal cancer kind of view. And I think that we need to change that view a little bit. Not all drugs are going to work in an unselected colorectal cancer space. And there is an immense need to understand that biology before launching the next phase 3 trial that gives you, a few months survival benefit. Because I think, we look at these survival benefits and we say, oh, it's only like a 2-month survival benefit or 3-month survival benefit. But when you look at the trials in general, there is some biology selection here which happens because there are a few patients that always work. When you look at those PFS curves, it points that out. We just have done the trials before we understand that biology. So hopefully we can do a little bit better job on that.
Do you want to comment then on like different, we're very crude and we talk about liver versus non-liver. Dr. Modeste early on had talked about right-sided versus left-sided. Do you think there's anything that we're going to do to understand either of those? Why those are biologically important? It's very crude. My colleagues in lung cancer are talking about specific mutations, and I'm talking about right-sided and left-sided or liver mets versus non-liver mets. Any thoughts about that?
Okay, I think there are two different stories in a way, because for left and right, I think our problem is that we've made a dichotomous thing out of it, and I think it's from a biological standpoint, I think it's easy to believe in a continuum hypothesis. So there are several aspects that change biologically over the colon in its entire length, which is maybe ligands, mutations, expressions, and whatever. And they are preclinically and also from biology, there are good data to explain that. And I think if you take that seriously, you can also believe that left and right is wrong, and that maybe we should limit EGFR to sigmoid and rectal cancers, because even the descending colon is maybe not so attractive. At least the biologists say that. And also you can argue the other way and say the transverse colon is maybe still in the benefiting space. So that's a continuum thing, and I think we will never really solve that.
Can I take moderator's privilege, because there's something that I wanted to ask you that you were strong about, was about anti-EGFR. And so do you think there's ever a time further, particularly in the United States, where we tend not to use EGFR up front, unlike your FOLFIRI cetuximab patient, that I think the data in first line is pretty strong. It's been really hard, and I've actually tried to having run second line trials with anti-EGFR, to try to get all the data together, but they tend to be smaller trials to look at EGFR, particularly anti-EGFR versus bevacizumab in there. What about in the salvage lines? Do you think that if you have someone who has a right-sided tumor who is RAS, who is triple wild type, for example, would you use an anti-EGFR in such a patient who has a right-sided tumor?
Ultimately, yes, but not necessarily early on. and not necessarily with great hopes, because my experience does not stand for great hopes of efficacy in that scenario. But this is also the problem. Of course, you find left-sided tumors on the right and right-sided tumors on the left. That's the problem with the definition when you do not refer to biologic information.
Right.
But to a location. So I wouldn't deny that ultimately, but I think it's not a great choice.
So let me see. Are there any later line therapies that you would expect to move up in the treatment algorithm for CRC? I think I'm supposed to talk a little bit now, and then we can discuss. And what ongoing trials are you following? And these are ones that have been presented recently. One group that we didn't talk about so much, but I think you obliquely, both of you obliquely mentioned, was HER2, which is still rare, but we have drugs for this thanks to our friends in breast cancer, where it's much more important, and also in upper GI. This is one that I'm intimately involved with. I published this recently with zanzalintinib, which is a small molecule tyrosine kinase inhibitor, plus atezolizumab, a PD-L1. My colleague Anwar Saeed presented this at ESMO, and we had a simultaneous publication. This was Stellar 303, really trying to leverage some of the earlier data that we had with small molecules together with PD-1s, particularly. And one of the other things that we really wanted to look at, and I pushed hard, in fact, to look at, was the question about liver versus non-liver. And this is actually the trial design. Zanzalintinib is not approved anywhere, but it's similar to cabozantinib. This was a large randomized trial, 901 patients. It did blow up in size as we were trying to enrich for the 30% of patients who do not have liver metastases to be able to have enough power to look at those. So it was zanzalintinib plus atezolizumab versus, at the time, which was a more standard worldwide comparator arm, which was the label regorafenib. If this trial had been done today, I think as to what you would probably trifluridine tipiracil plus bevacizumab would be a better control arm. Overall survival was the endpoint, and it was positive, but once again, not the home run necessarily that we had hoped, with a hazard ratio of 0.8. It's a little hard to do cross-trial comparisons. The one that probably has the best against an active control, of course, is Sunlight, which was an active control. This was against an active control, though Dr. Modeste has pointed out that regorafenib is not necessarily the most active control, but it was better. Interestingly, despite the fact that we're specifically looking again at patients without liver metastases, really this hazard ratio for overall survival of 0.8 was almost seen in exactly all the different subgroups, whether you've had prior anti-VEGF, whether you had liver metastases or not, your RAS. There was some early data about RAS, so that was something that we're specifically looking on. And not always the case, but it didn't really seem to matter where you lived in the world. This is PFS. And what you can see is that early drop-off, as you were discussing, but still above 50%. And there was an improvement in PFS with a hazard ratio of 0.68 versus Rego. This is the point that is probably most important, is that with this dose of zanzalintinib, 100 milligrams, while regorafenib, particularly given this way, has toxicity. And before the meeting, we were having discussions about whether the juice is worth the squeeze with some of these, is that zanzalintinib plus atezolizumab did have significantly more toxicity. Not so much grade 3, but any grade toxicity still is important to these patients whose performance status is not perfect and have been through a number of lines of therapy. This is another trial that will actually be presented by your colleague, Dr. Kopetz. This is Breakwater. The data which it presented was with oxaliplatin-based therapy. This is with irinotecan, particularly in parts of the world where they use irinotecan more, to show that it looked very similar, and that, not surprisingly, that adding EC, encorafenib plus an anti-EGFR to active chemotherapy was better than chemotherapy alone in this bad disease. This was also to be thrown in as about other trials that we're waiting for. We know that, I think was mentioned earlier, about anti-HER2 therapy, but we didn't have time to go into it in detail as we're getting more and more biomarkers. But tucatinib plus trastuzumab, as well as fam-trastuzumab deruxtecan, and other combinations have activity in the roughly 5% of patients who are HER2 positive. The question is what happens when you bring it in. So at this point, before we go to the conclusion, we still have, is this 2 minutes before we have questions or 2 minutes total?
7 minutes.
I have 7 minutes, thank you, before you get to go to the receptions or just to sleep and think about this. And so maybe I can ask 1 or 2 more questions that have not been asked. I'm just curious. Dr. Modeste had a good point, is that I can always fill time by asking, how do you do this in Europe? And so one thing that has been very much on people's minds, thank you, recently has been DPD or DPYD testing. And this is really finally making it, because I think that our European colleagues have been, they've been doing this longer than we have. There's a black box now warning for capecitabine. 5-FU, we talk about in the NCCN guidelines. We have not totally figured out how to do this in a rapid fashion, and I was just wondering how you do it at your institution.
The fun thing is, when I was trained in Munich, it was a standard of care and it was done within a day. Mm-hmm. Then I moved to Berlin at the Charité, and no one was aware of that because it was not mandatory. And after a few years, it was the same as in the US. The authorities came and said, you have to do that. Mm-hmm. So now we do it, and we do it from blood testing, and we usually have the result in 2 to 3 days. So
yeah, I would say that at least at our institution, it's probably, because it's a send out for at least for now, closer to a week. That's sort of in patients getting a port, they're doing other things as well. How about at MD Anderson?
Same. It's about a 1 week to 10 days, 7 to 10 days turnover. So I guess my question is, since you get it so quickly, how do you modify your first-line treatment, knowing that 5-FU is still the...
Depending on the activity. Yeah, I mean, if you have to reduce, you reduce. And if you have a finding that you can't use 5-FU at all, you have to find an alternative. Which I think out of the box can be trifluridine tipiracil. You can use that. Raltitruxat is something you can use, or as one.
Okay, well, that I was just curious because you've led this, and this is still not. I'm actually curious in the people around the room, if everyone, you don't have to raise your hand, but I'm curious what percentage of patients out, particularly once you get away from centers that have been legally mandated because of a lawsuit to do that, whether or not it's really swept the country yet. But we still have not figured out exactly how to do it, the best way possible. All right, we do have some questions. Regarding KRAS, there are pan-KRAS inhibitors in development. Do you think these will lead to less resistance or escape mutations? Anyone want to? I can maybe jump in with that. And the answer is, I hope so. It makes sense because, as Dr. Modeste was saying, you actually pay for broader activity with more toxicity with almost every drug that we have. And I would say that I've been working with both, and that the question is whether or not the problem, you can't necessarily compare trials, but I think the pan-KRAS inhibitors do have more toxicity, not surprisingly. In some ways is that I think that the G12D inhibitors and the more specific inhibitors probably have less toxicity. So I wonder if what will happen at some point in time is that if you know what the mutation and you have a drug for that, you may start with that, whether or not, I think there'll be a whole set of trials to see whether you can salvage them later. If you don't have a specific, like a rare mutation, then you're probably going to be doing a pan-RAS inhibitor. Anyone else have any other thoughts?
Agree.
And then the other question, though, that also seems to be, I think is really important, this is a colon cancer talk. Most of the best data has been in pancreatic cancer, which of course, unmet need. I think the jury is still out if the efficacy is as good in colorectal cancer, either alone or in combination with anti-EGFRs as it is in pancreatic cancer. If zanzalintinib is approved for later line colorectal cancer, where would it fit in with TAS-102 Bev and fruquintinib and regorafenib? Anyone want to take, it's probably not fair for me, but to take a stab at that.
It's probably very fair for you. I think you should answer that question since you wrote the trial up.
I pass on that. And so but if anyone, I'm curious, I know what I think, I'm always curious what other people think. But it's a trial, because I would not be surprised if it's approved. I'm not part of that, I'm just an academician, but I do know that they're going for FDA approval.
Yeah, but I think it should be placed after trifluridine tipiracil plus BAF for reasons of efficacy and also of side effects. I think okay, cross-trial comparison is what we like best and should do. But of course, we have to take a decision. And I think given the gain in benefit and also what the toxicity means, I mean, adding bevacizumab is completely different to having this combined drugs and also TKI in the game.
I have to agree with what you had said earlier, which is that, let's face it, Bev has minimal toxicity other than rare bad things. And the benefit this is one of the unusual, Sunlight was one of the unusual trials where the benefit in the phase 3 trial was at least as good as in the earlier Pfeiffer phase 2 trial. Usually there's the reversion to the mean, and the benefit that you see in a second line trial that leads to the to the phase 2 trial that leads to the phase 3 trial. Usually the phase 3 trial is not as good. This is one where the benefit is there. I can't argue with that.
Yeah, I mean, to be fair, we've brought this point up a couple of times. Just remember that about 25% of patients had never had any VEGF inhibitor before, and we should be really careful about cross-trial comparison, because when you look at Stellar 303 and you see regorafenib, your median overall survival is about 9.4 months. That's like a 2-month improvement of on the same drug, just a different trial, right? So I think while a lot of what you use, whether it is regorafenib, fruquintinib, TAS-Bev, or Zanza plus Atezo, will depend on patient preferences, the toxicity patterns that you are dealing with, and who is in front of you, right?
It may also, perhaps we also know how to deal with regorafenib toxicity more than in the original trials as well, or pick patients for them. And then it looks like one last, and this is a question I've actually been sort of interested in asking y'all. Single agent versus double immunotherapy in MSI high frontline. And once again, if you look, the added toxicity of adding a CTLA-4 is about the same as the added benefit in progression-free survival. So are there patients that you would use single agent? This question had to do about pembrolizumab. What patient would you give single agent to who's MSI high in first line?
I can't imagine, to make it short. Why?
The question also, there are some anecdotes about salvaging by adding a CTLA-4 later.
I've never managed in my whole life. Maybe I lack the experience of success salvaging someone. I've tried that.
What if you had a patient who had autoimmune disease and you were more concerned about? Because it's not uncommon. Someone has ulcerative colitis, or someone who has who has some other lupus, some other significant autoimmune disease. But
these would not have been on the trial, so it's really hard to take any kind of decision or recommendation on these patients. But based on what has been presented on the trials, I hardly see a proportion of the population that should be preferentially offered monotherapy.
Yeah, I mean, I would sort of agree with that. It's hard to find a population that would be eligible for immune checkpoint but not eligible for dual. However, there are cases where you may want to be careful, and it all sometimes depends on how the patient also, a 40-year-old who has perfect lungs and can tolerate a pneumonitis episode may be different from like a 74-year-old with COPD. And COPD is not an immune-mediated disease, but now your lungs are limited. And if you have pneumonitis, And these drugs are not without their share of side effects. You know, once you've seen a patient and you've lost a patient to pneumonitis, you'll start respecting this is not water and should be treated carefully.
So I think we have reached our time. I'm asking the organizers, is that correct? All right. So first of all, I'd like to thank my fellow speakers and panelists for such giving such wonderful talks. I want to thank you for sharing your evening with us, and I hope the rest of the meeting is a good meeting for you all. Take care.